Greetings. My name is Michael Fraley. I'm a paramedic and the coordinator of the North Central Regional Trauma Advisory Council. Tonight, I'm going to do a brief presentation on pelvic trauma. Do get in a bind. First question is how bad can it be? How many pelvic injuries occur in the population? Well, generally the incidence is approximately 20 to 37 injuries for each 100,000 population. For Wisconsin in 2020, our trauma registry shows that we had 1,558. About 3% of skeletal injuries are pelvic injuries, while 9% of all trauma admits are pelvic injuries. So you can see how they are serious fractures. The mortality is kind of tough to get a handle on, ranges anywhere between 9 to 20% for the most part, but it can be as high as 45% when we have an open pelvic fracture, which luckily is fairly rare. Only about 3% of pelvic injury cases are open. Just a little interesting history. We know that the treatment of fractures by splinting broken bones goes back 5,000 years to the Egyptians. But the first mention of specific care of a broken pelvis was in 1859. A French surgeon, Joseph Francois Malgain, published multiple books about fracture management and talked about the injuries from falls, but also patients that were run over by horse-drawn carriages. Obviously, he didn't have radiology to help him with the assessment back then, so he described how the fractures were identified through careful physical assessment, palpation, manipulation, and even measuring patients' pelvises. Management back then was 45 to 50 days of being completely immobilized in traction in bed. Malgain also was the first to describe the poor outcomes commonly seen with pelvic fractures, and he said, "If life is preserved, lameness is very apt to ensue." So what does the pelvis do? Why is this important? Why is it such an issue when it becomes broken? Well, it does a lot of important things. Certainly it bears the weight of the body. All of the body as we're standing upright rests on the pelvis before it's transmitted to the legs and to the ground. The pelvis also serves to protect some of our vital organs as a bit of a bony shield all the way around. As I mentioned, our legs are connected through the pelvis. So all of our movement, everything from sitting, standing, running, jumping, bending, all those sorts of things rely on a properly functioning, intact pelvis. Anatomy of the pelvis, the core bones we consider of the pelvis being the ilium here, the pubis, and the ischium. We also know that it's fused onto the spine, the sacrum and the coccyx here kind of form that posterior portion of it. We talk a little bit about the iliac crest, which is part of the ilium, but it's kind of that wing that's palpable out there, and we'll see another image of that here in just a second. You'll hear discussion of the acetabulum. That's the socket here where the femur joins the pelvis to form the hip. Fractures to that area can be painful, or certainly a problem for folks. They're very difficult to fix. They take us specialty surgeons to do that, but they're generally considered stable fractures. Here's another view of the pelvis. You can kind of see how these iliac wings kind of protrude out there and are easily palpated. You can see where the coccyx is back here, the sacrum and the coccyx, and how that can be broken. And then as the pubis bones come together here to form the pubis symphysis, you can see how that can be palpated from the front. I mentioned that the pelvic bones help protect some of the organs on the inside. Now this picture obviously isn't really to scale. It's not really how it lays in there, but it gives you an idea of how some of these organs, particularly the bladder, the urethra, large intestine, and the reproductive organs sit inside of that protective pelvis. A really important point is how much blood flow is going through the pelvis at any one time, because that's a really major complication when we have pelvic fractures. Just thinking about all the vasculature that's in there. We have blood flow coming through to go to the legs. All the blood that goes to and from the legs comes through the pelvis. All of the blood flow for the organs that lay inside of that pelvis, obviously, come into the pelvis. And then the blood flow for the bones themselves. As we know, bones have circulation. So all of that blood flow is coming in there as well. And you can see that in this plasticized body here, just how much blood flow is in that area at any one time. So let's talk a little bit about mechanism of injury, how these patients get injured, and then we'll move into the fractures themselves. I always used to think that pelvic fractures were only from falls from great heights, or really big mechanisms of injury like motor vehicle crashes or machinery falling on folks. But it turns out that there's some other things as well. First, we'll kind of think about the significant pelvic fractures that occur, ones that are really a threat to life for patients. Now, these are chiefly caused by motor vehicle crashes, motorcycle crashes, about 10 to 20% each. Or excuse me, 55% are caused by the motor vehicle crashes. 10 to 20% are the car versus pedestrian and motorcycle crashes. Falls are 8 to 10%, and other crushing injuries are 3 to 6. But when we look at all pelvic fractures, the most common causes are falls from standing height, particularly those in the elderly. 63% of all pelvic fractures are caused by a fall from standing height, whereas 18% are a more significant height, 9% from those motor vehicle crashes. So yes, we have to think about that patient that's fallen and can't get up, that ground level fall, the trip or the stumble or the fall, all those, lift assist type patients that we get called out to can be pelvic fractures. 73%, as I mentioned, of pelvic fractures are elderly patients. Again, many of those are not the significant type. They're more isolated and stable types of fractures that aren't initially going to be life threats, but they are bad in the long run. They can be devastating. These patients are more prone to complications like ulcers and pneumonias and urinary tract infections as they heal. Plus, they just have a difficult time healing to begin with because of just their age. The body doesn't heal as well as the older we get. Plus, you have other comorbidities, diabetes, cardiovascular disease, that sort of thing. So the mortality in this population is a bit higher, 20% within 30 days, 27% within a year, and then 41% mortality rate within 3 years. And those that do survive have a substantially lower level of physical functioning compared to the general population because of the injury. And almost a third of them, 31%, are discharged from the hospital to long-term care facilities. All right, so let's talk about the fractures themselves, the different types that are out there, and we'll kind of mix and match the types of fractures versus the mechanism. They kind of overlap as you describe them, but we'll work our way through them. The first thing we want to think about is the iliac crest fracture. So again, that iliac wing that kind of protrudes out there, you can imagine is easily injured because it's palpable from the outside. So you can kind of see that little blue line through there. Imagine that that's a fracture line. Something hit that iliac wing from the outside and broke it off. Painful, a serious injury, but it's a relatively stable injury. As opposed, though, to the pelvic ring fractures, as you can see on the right side here, that disrupts that entire pelvic area. That entire pelvic ring is now disrupted, and we're going to get some complications from that, and we'll talk a little bit about that. So pelvic ring fractures can be from a couple different mechanisms. We have the pubic ramus fractures, both the inferior, as you can imagine, that can be broken. Somebody falling on their butt a little bit too hard can break that. Just that inferior pubic ramus, relatively stable. Again, painful, tough to heal from. But if both of those are broken, the superior and the inferior, then that's a little bit more serious. We're more likely to see some internal injuries with that, particularly the urinary tract trauma. Those are sometimes called saddle fractures, as you can imagine, falling onto a saddle of a bike or a horse or what have you. We have vertical shears, really a mechanism of injury, how a pelvic ring fracture occurs. Again, you can see this entire ring has been disrupted by some force that came up from below, probably transmitted up through the leg, through the hip bone, that acetabulum, and shears that entire wing of the pelvis off. We do see some shortening of limbs in that sort of situation. These occur maybe in 5 to 15% of patients. Lateral compression is probably the more common mechanism that we see in trauma coming from that outside, again, being compressed from the outside. Getting hit by a vehicle from the side would cause that. 60 to 70% of injuries tend to be those lateral compression injuries. And then there's the anterior posterior compression, or the front to back, or it could be back to front type of injuries, where the person's kind of smushed between two things, maybe two vehicles, or a forklift with a box on it, or some sort of machinery, semi-truck and a loading dock, something along those lines, and they're compressed front to back. That kind of cracks open that pelvic ring. Maybe you have a fracture here right at the pubis symphysis and the iliosacral joint there, and it just splits that pelvis wide open, and that becomes what we call the open book fracture, because the wings of that pelvis just kind of lay open like an open book laying on a desk. We see that in about 15 to 20% of cases. Show another image of that here. Again, so this is a CT scan. You think of it as you're looking down the axis of the patient, so you can see that SI joint here is split wide open, compared to the one over here that you can see the joint, but it's still intact. This one's split wide open, and you can see the wing of the pelvis is laying open much more than it is on this side. So it's creating a much more open pelvis in that situation. Here's another example, just another X-ray of a pelvic ring that's just split wide open. You can see the disruption here and how much wider that pelvis now is. Another type of injury you might hear is called the avulsion injury. This is really where a muscle or the tendon is attached to the bone, and maybe because of athletic competition or what have you, or stretching or weightlifting, the muscle and the tendon actually breaks off a piece of that bone. The muscle and tendon is stronger than the bone. Young athletes is where we tend to see this. The muscle is so strong it just breaks that bone right off. Participating in sports, these are generally, again, considered stable fractures. Might be very painful, but they do heal with rest. Okay, so getting into the assessment of our pelvic injured patients, we won't go real in depth on a full physical assessment, but certainly we endorse using some sort of an organized primary and secondary approach to a patient, PHTLS method or an ITLS method, of going all the way from your scene approach to general impression primary survey. But somewhere in that primary survey, or at least for sure within the secondary survey, you're going to start to pick up signs and symptoms that hopefully will lead you to think about a pelvic injury. Certainly our two most common ones, the things that are probably going to stick out the most, would be pain, really anywhere in that midsection, the hip, the groin, the pelvis itself. Tenderness, remember, pain is something that the patient reports before you even touch them. Tenderness is pain that we elicit by touching the patient or moving them. Other things that we might see: swelling, instability. We'll talk a little bit more about that as we do our pelvic assessment. Crepitus, that's that terrible sound, or really it's more of a feeling that you get when you move bone ends against each other and they kind of grate or rub together. You might see a lengthened or shortened leg. decreased peripheral pulses, motor sensory deficits, hematomas, contusions, discoloration, bleeding under the surface of the skin, whether it's in the abdomen or the pelvis. You might see it in the groin. It's common to see it in the scrotum and down into the thighs. External bleeding may be occurring, whether it's a break in the skin or through channels such as the urinary meatus or the vagina or rectum. Any of those places where blood's coming out, we want to be suspicious that it could be from pelvic trauma creating damage inside of the pelvis. And then the biggie is if we have a patient who's showing some signs of shock, hypotension, but we don't have external bleeding and we don't have any other obvious causes, think about pelvic injury. So I mentioned doing the pelvic injury assessment. We want to do a little bit of palpation. Once we've done this observation to begin with, now we're going to start doing some palpation to see if we have quote unquote a stable pelvis. So we're going to apply pressure, gentle pressure. We don't have to be real forceful with it. It's not a pressure contest, but by pushing in on those iliac wings towards the middle, the iliac crest, see if we can feel any instability, or if the patient has any tenderness when we do that. We can also push down on those iliac crests. Again, gentle pressure, doesn't have to be real strong. Now, if we get any pain with this or that instability, tenderness, then we can stop. We don't need to continue doing it. We don't need to check it again. We're just going to assume that it's injured and move on. The more we move it, the more damage that we can do, the more bleeding that we can cause. The other thing that you can do is, again, that pubis symphysis. Remember that where the bone comes together there in the front, you can feel that as well. A little bit of pressure on that would also elicit some tenderness or maybe some instability if there was a pelvic involvement. Any other pain that the patient may be experiencing in that area, again, we kind of have to be overly sensitive and just assume that it could involve the pelvis, any of those pains that show up in that area. Again, the bruising and the blood that I mentioned, and then just a reminder to look for that decreased CSM, distal pulses, sensation, motor function. Keep in mind, if the patient has blue feet, they shouldn't have blue feet, as opposed to the blue-footed booby here. That's a tropical Eastern Pacific bird, kind of an unusual bird, but he normally has blue feet, so that's fine for him. But if your patient does, that's a problem. Think about any other injuries that the patient may have. We know that patients that have pelvic instability, pelvic fractures, are likely to have other trauma because typically the mechanism's fairly serious. So a significant number of them have traumatic brain injuries, other long bone fractures, thoracic injuries, maybe spinal injuries as well. So do a thorough assessment. Keep your possibilities open and check for all of those things as you're doing your assessment. Okay, a little bit about the management of these patients then. Certainly we're going to start with the ABCs, and we do that all the time in trauma because that's what works. We have to take care of the basics, the ABCs of the patients, keep them breathing, keep their airway open, and keep their circulation intact is the mainstay for trauma care. No different in the pelvic injured patients. So pay attention to those. If there's any deficits to those, manage those quickly and effectively. We also need to think about our spinal motion restriction and whatever that may be to your service, your protocols. I know that's changing quite a bit these days, and we're looking at it in a lot of different ways. It may still mean putting the patient on a backboard, particularly if the patient's unconscious, not able to give you a good survey. They're seriously injured. Time is of the essence. Backboards are still a good way to move patients, and if they're not able to help you rule out any other injuries, then it's probably best to implement whatever spinal motion restriction methods that you have and get that patient transported. So we'll talk a little bit more as we go along about management of shock, certainly the stabilization, pain control, and transport methods we'll cover as we continue to move through here. So first off, the stabilization, the big ticket item for this presentation. do get in a bind is the title of my lesson. And it's because that's what our current treatment for suspected pelvic injuries is to do some sort of binding or some sort of pelvic stabilization. The National Model EMS clinical guidelines, the general trauma management protocol or guideline specifically says, if the pelvis is unstable and patient is hypotensive, place a pelvic binder or sheet to stabilize the patient. So that's those protocols that are recommending that now. We'll talk about a couple other guidelines as we go along here. But why do we stabilize these patients in the first place? Why all this talk about using some sort of a pelvic binder or a sling or any sort of pelvic stabilization? What does that do for us? Well, probably the first thing is when we think back to that open book pelvic fracture, where the pelvis is kind of spread open now, as you can see in this picture here, where you have more space in here. And as we have that injury, we have that trauma, we're going to have bleeding. Potentially those large vessels that we talked about earlier, we could bleed a lot, liters and liters into that pelvic space. And there's really no other good way to stop that bleeding. It's not really something you can compress, put a bandage around or anything along those lines. So one of the best ways we can do that is kind of the internal tamponade, the internal pressure that's created by having an intact pelvis. So if we can put a stabilization device on that patient and close that fracture back up, close that open book back so that the patient's pelvis is back the way it should be, we're going to have less space here. There's less space for blood to go into, which helps slow it down and tampen out the bleeding so that it stops sooner. Also, by stabilization, we're hopefully creating less damage. The more that those bones are unstable, just the same as with any bony fractures that haven't been stabilized yet, the more they move around, the more damage they do to nerve tissues, soft tissues, blood vessels, muscles, that sort of thing. So by putting that stabilization on there, we're going to help decrease the amount of additional injury and additional bleeding that's going to occur. And of course, it's going to reduce pain. We know that from other fracture types, is whenever we stabilize them, put some sort of a splint on them, they tend to be less painful because there's less moving around and creating more damage for those patients. So this is kind of that concept, is before the sling was put on, and then afterwards we close that open book fracture back up and stabilize the fracture. If you've been in the business for a while and taken PHTLS classes in the past, and some of the other trauma classes, use of pelvic binders or pelvic stabilization has not always been the recommendation. In fact, the last couple editions of PHTLS before this 9th edition that's currently out, they were kind of on the fence about that. They said, yeah, we know that those exist. You could consider it, but we think that they're only good for that anterior posterior compression fracture or that open book fracture. And we're worried about if we use them on other types of fractures that we're going to create more damage. So they did not specifically endorse that. Well, there's more information now that it turns out that the good that we can do by binding that pelvis and stabilizing it, no matter what kind of fracture it is, outweighs the risk that we're going to do any damage to it. So PHTLS does now recommend use of a pelvic binder. The benefits outweigh the risks, like I mentioned, but they point out, and we'll see this in a couple other protocols as well, is that proper placement really is the key. We have to put the pelvic binder, the immobilization device, in the right spot for it to be effective. So where is that right spot? All of the products that are out there for use in the EMS market right now recommend putting the pelvic binder at the level of the greater trochanters. So the greater trochanters is this bony prominence of the femur, kind of that hip bone, we might call it, that you can feel on the lateral aspects of your thighs. The pelvic binders do not go at the level of the iliac wings or the iliac crest there. That is too high. That compression is not going to be effective at stabilizing that fracture. In talking to the trauma facilities in our area, that's the thing that they see most commonly, is that the pelvic binding device is set too high. So we've really got to remember, get it at the level of the greater trochanters. You can feel this on yourself by kind of reaching down, you know, reach up kind of at your waist level a little bit, you'll feel the wings of your pelvis. Go a little bit further down and you'll find those greater trochanters. It tends to be, if you put your arms down at your side, kind of the base of your thumb or maybe the wrist level is where you're going to find those. If you're flexing your arms up to feel them, you're probably too high and you're feeling that iliac crest. So be sure to identify the proper placement there of the greater trochanters. Just a couple other protocols, examples of mention of pelvic binding. The UK consensus statement that was actually out since 2014 talks about the pelvic binder as an intervention rather than a packaging device, and it should be applied early. I'd say, you know, of course, not everybody needs them. At that time, they didn't identify any one particular binder better than the others. Should be placed next to the skin and prior to extrication. EAST, which is the Eastern Association for the Surgery of Trauma, really big group. They really make a lot of the guidelines and recommendations and protocols, you know, for surgical and hospital-based trauma care. They identified back in 2011 that use of pelvic stabilizers, you know, there's low potential for complications, relatively inexpensive cost, and the benefit of stability. So that should be considered for emergent application for all hemodynamically unstable patients with pelvic injuries. So again, a broad category of hemodynamically unstable patients with pelvic injuries. So just looking at a couple other protocols, and this is actually from an article in GEMS a couple years back, again, 2014. You know, a conservative approach for use of pelvic immobilization devices for stabilizing is in a trauma patient, one of these three things: obvious signs of pelvic injury or instability on the pelvic exam. You know, so your hands-on exam, you find some signs of it, or you have a patient who's hemodynamically unstable, they're in hemorrhagic shock or you suspect that they are, and they're saying that they have, you know, pain in their pelvis or low back or lower abdomen. Even if, you know, you did an assessment and you feel like the pelvis is stable, still think that it could be the pelvis and apply a stabilization device. Or the third one would be if you've got a patient who's in shock, altered mental status, you can't get a good survey on them. And again, even if you aren't finding something specific in the pelvis, because of the likelihood that is bleeding severely, a pelvic immobilization device could be indicated. So a couple different products on the market, three ones that are probably the most popular in the EMS market right now. One would be the pelvic binder. I enjoyed this, that they advertise on their site that they're as seen on Chicago Med. So you might have seen this device used on television. It kind of looks like a corset, you know, maybe. You can kind of see here, this is a smaller version of it, the pediatric version. This is the adult version. And you kind of see here this series of, I kind of call it the ropes and pulleys, that as you wrap that around the patient, there's some Velcro straps. You have to size it properly. And then once you get it around the patient, you pull on this red cord, and it'll using these strings here, it'll kind of bind that closed and pull it together. This lesson isn't about the proper use of these devices, so I'm not going to go through each specific step of using them, just kind of pointing out some of the devices that are on the market currently. So this is the pelvic binder. It retails for about $180. And again, there is a pediatric size available. The SAM pelvic sling 2, their second version of it, features the auto stop buckle. So this orange buckle here, one of the things that's kind of unique about that is, again, you put it around the patient at the level of the greater trochanters. With one hand, hold on to this orange buckle. With the other hand, you're going to grab the black strap on this end and pull it through this buckle. When you hear a couple ratchets, a couple little snaps in that buckle, then you stop and you apply the strap back to itself. It'll Velcro onto itself, but that ratchet is supposed to be letting you know when the right amount of tension has been applied to that patient. The SAM Pelvic Sling 2 retails for about $79. They have a standard version. They also have a small and a large. Their product information says that their standard fits about 95% of the population. Then there's the Aero T-Pod. This one's probably more popular in the hospital settings. It looks kind of similar to that pelvic binder. Applies a little bit differently, but again, it uses kind of that pulley system there to pull tension on the patient, and then Velcros back to itself to hold in place. One thing that was pointed out by one of the orthopedic surgeons in the area, he kind of felt that the T-Pod and the pelvic binder were preferable, mainly because of this this wider belt compared to the belt on the pelvic sling is a little bit smaller. He felt that might lend itself to a little bit more uniform pressure and also more chance that you're going to be in the proper position with that. So, but any of those three products are out there on the market currently. The Aero T-Pod, I think, retails for about $80. And then it was mentioned a couple times is the pelvic sheet wrap. Just using a sheet, wrapping around the patient at the pelvic level. Again, you'd still want to be at the pelvic, or excuse me, at the greater trochanters. And then pulling that real tight and then tying a knot, or maybe using some clamps to hold that in place. It's a possibility. It can be done. It is mentioned in some protocols. But this article from GEMS kind of pointed out that it's just not consistent. There's really no way to know how much pressure you're pulling, and it's tough to keep that pressure in place because it kind of comes loose sometimes. So one option, and I know there are other things out there that EMS folks do. We're creative when it comes to this sort of stuff. Use of a KED device upside down has also been suggested. Again, not what it's designed for. Not really sure if you're pulling the right amount of pressure on them, but it has been suggested. Additional treatments, certainly we want to treat for shock, which might include getting IVs in the patient, considering some fluid resuscitation. Certainly, check your protocols. Keep in mind the permissive hypotension that we prefer in most of our protocols these days, and don't flood the patient with fluid, particularly in a pelvic trauma patient. If they're in shock, it's because of that bleeding, and the more fluids we push in there, the more chance that we have of actually worsening that bleeding and thinning out their clotting factors. Pain treatment certainly may be indicated. Narcotic analgesics, again, based on your protocols. Of course, being careful of any hypotension that the patient may have. Hopefully you've seen these. This is the current state of Wisconsin trauma field triage guidelines, the document that's out there to kind of help you identify when a patient should be transported to a higher level of care, a level 1 or level 2 trauma center, if at all possible, which patients should be flown from the scene directly to those trauma centers, who you should be calling ALS for, that sort of thing. These guidelines are meant to help you make that decision. And we just wanted to point out that right here, you can kind of see it. Let's see if we can zoom in on it here. Step 3, pelvic fracture or unstable pelvis is one of the reasons that we would want to take a patient to a higher level trauma center whenever possible, a level 1 or level 2 trauma center. Those patients would also be appropriate for transport by helicopter. If you're more than 30 minutes by ground transport, safe speeds, of course, from a level 2 or level 1 trauma center, then consider use of a helicopter to get the patient there a little bit quicker. Those patients, when they get to the trauma centers, there's a lot to be done to take care of them, certainly because of the pelvic trauma themselves, but also because they're likely to have those other injuries. But some of the things that we might see in the care of those patients, this is what's called external fixation, kind of using what looks like kind of an erector set there, or some scaffolding outside of the patient to, there's pins that connect to that and go into the patient's pelvis to hold it back in place the way it should be to heal. They may also have to do internal packing for hemorrhage control, which may be what happened to this patient here. You can see a surgical incision and dressing there down the midline. The patient may also have to go to interventional radiology, where they actually use techniques of going through the arteries, kind of like they do cardiac catheterizations, to go to the site that's bleeding, to do embolization, to stop the bleeding internally. And of course, as mentioned earlier, the urinary or the urinary anatomy that's in this area is frequently damaged. Bladder lacerations, urethral lacerations, ureter lacerations. So urology and neurosurgery specialties are helpful. Other complications, as we mentioned, the bladder injuries, nerve. 33% of patients have some sort of nerve injuries. Rectal injuries, very serious if they go unidentified. And we also know that these patients have loss of mobility, they have long-term pain, loss of range of movement. It can be difficult for them to bear weight. Again, think of all those things that the pelvis does for us, and whether we're sitting or standing, moving about, weight is being applied to that pelvis. So damage to it is going to be very serious to patients in the long run. Of course, they're at risk for other circulatory injuries and sepsis. Thank you very much. I hope this has been helpful. Feel free to contact me through the North Central RTAC with any questions.